Welcome, everyone. We're going to go ahead and get started. It's my pleasure to welcome all of you to the Fairbanks Center lecture series. I have a few general announcements, and then I'll get to introduce Lucia. I'm pinch hitting a little bit here, so I actually don't have any formal notes, but fortunately I know her well and can say wonderful things about her. Just a few general housekeeping announcements. If you would please silence your pagers and cell phones, we would appreciate it. And if you need to take a call, it would be great if you could step out of the room since we are broadcasting to several locations. We'd like to welcome those who are listening from IU Health West, Arnett, Ball, and Saxony. So we're glad to have some of you on the line remotely as well. Any other housekeeping that I'm not thinking of? All right. Nope. Okay. So it's my pleasure to introduce Lucia Wocial, who is our nurse ethicist. She said if I can say that without getting a lisp, I'm lucky. It is wonderful to have her here today. She's been with IU Health since 2007 and has developed a robust program in nursing ethics throughout our health system. Lucia also chairs the Consultation Service and is now the co-leader of that service, and is going to talk with us today on ethics consultation, when to call, what to expect. So please join me in welcoming Lucia.
So good afternoon. I actually would rather be a radio personality than have anybody look at me. So if you just want to look at the slides and ignore the woman at the podium, that would make me feel great. Can you hear me all right? Great. Okay. So I'm going to talk to you about ethics consultation, what to do, or when to call and what to expect. I don't ever read my objectives when I teach classes because I'm convinced you can read them better than I can, but this is, what I plan to do today. So this is a schematic that shows all the ethics resources that are available to folks at IU Health. I will say this is predominantly on the main campus of the Academic Health Center, but some of the foundations of this apply to the health system. I do not have a laser because I'm always afraid that I'm going to put somebody's eye out with it, so I'm just going to talk about what you're looking at. So you can see at the top of our infrastructure, we actually have, at the IU Health Board of Directors, we have something fairly unique at IU Health, which I think is a really important aspect of the ethics resources. We have something called a Values Committee. And the Values Committee is a group of people. Dr. Steve Ivey, who is our Senior Vice President for Values, Ethics, Social Responsibility, and Pastoral Services, going for the longest title on the board. He sits on that committee, and the coolest part about that is it's their job to remind us daily what our mission, vision, and values are, and how we at IU Health stay true to that. The Medical Staff Committee oversees the Ethics Committee, so ethics is housed within the Medical Staff Committee. You'll see the pink on your far left, which is the Ethics Committee. They do several different things related to education, service, research, and membership. Over on the far left is the Fairbanks Center for Medical Ethics, which I'm going to talk to you a little bit about. Now, I always tell people the reason the nurse ethicist is on here is because this schematic was originally created for a magnet designation opportunity, which is a nursing certification body. I thought about deleting it, and then I decided that actually it's not about me, it's about the role. There are probably fewer than 20 individuals in the United States who hold the title nurse ethicist whose employers think that nursing's presence at the table is valuable enough to actually have that position, and IU Health is one of them. So I thought, what the heck? I'm going to keep it up there in the grid. And then I'm going to talk, obviously, about our Ethics Consultation Service. But this, part of the reason I show this is I think people really don't appreciate the depth of ethics resources that are available to people who are affiliated with IU Health, and I think it's pretty amazing. So this sort of gives you a schematic. So the Charles Warren Fairbanks Center for Medical Ethics has been around since 2005. Heads up, save the date. This is our 10-year anniversary coming up in the fall. We are a foundation endowed, supported, freestanding clinical ethics center within IU Health. So while all of the faculty have shared appointments, I'm in the School of Nursing, Lexi Torkey is with the School of Medicine, as is Paul Helft. Each of them also have clinical practices. The center itself does not have a formal affiliation with Indiana University. It's just through its faculty. So what do? Well, we have a unit-based ethics conversation program, which is a complement really to ethics consultation. It's an opportunity for people to come together to talk informally about ethics challenges that they face in their clinical practice. We have a clinical ethics fellowship. We do accept applications, although this year's applications closed last week. I felt badly that we couldn't time this so that we could remind people again, but it'll come up again next spring. We have a lecture series, clearly, because you're here. This is part of it. We have a practicum and internship opportunities for students who are on the IUPUI campus in various different disciplines. We do clinical ethics research and scholarship. All of the faculty are involved in many different projects. The center does community service, and the Ethics Center provides administrative support for our Ethics Consultation Service. So, what about the Ethics Committee? The two chairs of our Ethics Committee here on the Academic Health Center are Rob Weller and Kurt Patterson. Each of them has been in that role for a period of time. They're very seasoned in what they do. What our Ethics Committee does is it works in three key areas. We do policy creation and review, although I'm going to point out, I'm going to show you some key policies. The Ethics Committee doesn't actually own any policies per se. We advise on other people's policy. That meets a regulatory compliance opportunity. We do education, which is our way of trying to prevent ethics issues from festering and becoming conflict. And then, of course, we do case consultation, which is how we respond when there are ethics challenges in clinical practice. So here's some sample ethics policies that I think are important for people to know about. When we teach our new fellows about ethics consultation, the one policy that I recommend that they carry with them at all times is our administrative policy for withdrawing and withholding life-prolonging procedures. This is a policy that lays out what we need to do when there is a situation where patients can no longer benefit from the resources that we have to offer them in terms of medical interventions, and how we walk through what that looks like, how we create ethically defensible opportunities, and what we do when there's a conflict involved, how we resolve that. Our Human Resources Department has a policy. It is called Staff Requests Involving Cultural, Ethical, and Religious Concerns, which honestly I wish they'd call it conscientious objection, because every time I go to look it up, I think of conscious objection, but this is how you would actually find it. This is a policy that states, if you as a healthcare provider have a moral objection to a medical procedure that's being followed, we will honor that moral objection to the best of our ability and not ask that you participate in that procedure. Now, you can't raise your hand and say, I will not take care of people with purple hair. That is not a morally relevant characteristic. It's not refusing to care for particular individuals. It's having a moral objection to a medical intervention. And there's a process that we ask you to follow in order for us to honor that. And then, of course, housed within the medical staff manual is our policy that lays out what ethics consultation is. So that's where the policy lives. So what about ethics consultation? This is, I'm sure, why you came, what we're going to talk about today a little bit. So ethics consultation there are three different approaches to it. One is a whole committee review, and in our organization, there are times when our ethics committee will be asked to weigh in on a specific case. It's usually when the case is setting, it's very complex, it has implications for perhaps a policy that needs to be generated. Some organizations have an individual ethicist who will go around and help resolve ethics consultation issues. And in our organization, we have the subcommittee or small committee review model. We refer to ethics in our institution as a team sport. We have an all-volunteer army. The volunteers consist of physicians, nurses, social workers, chaplains. I know I'm going to leave somebody out, so I apologize if I do. We have a lawyer. We have pharmacy. We have representatives from the dental school. So we have a very deep and rich group of individuals, which, by the way, from the Fairbanks Center standpoint, we are very intentional about an interprofessional model of involving people at all levels from all disciplines, because we think that's the best way to appreciate the perspective of how to resolve an ethics challenge. So I am actually going to read this slide to you because I think it's important. Ethics consultation is a service to help individuals address uncertainty or conflict regarding value-laden concerns that emerge in the course of patient care. Now, I read that because nowhere in that slide, and I'm going to emphasize this point again, does it say fix it. A lot of times when people call for help from us, they're hoping that we can fix their problem. We will do our best to help resolve this, but our goal really is to facilitate responsible decision-making in how you think about and how you care for patients. So what should you expect when you give a call? First of all, we're going to facilitate communication. People ask me all the time, so what actually is the ethics intervention that you provide? And what we try and provide is expert communication, clarifying misunderstandings, making sure that all voices are heard. We resolve conflicts, and we don't have a magic wand, and we can't necessarily fix it, but our goal really is to help resolve whatever the problem was that brought you to call us in the first place. We will mediate disputes. We don't have black and white striped things, and we don't blow whistles, but we do act sometimes as referees as a way of providing a neutral perspective, an outsider. Sometimes somebody from outside the caregiving team can provide a great perspective on the clinical situation and help people see things differently. We try and provide a safe space for discussion. I tell people all the time, if you have an ethics challenge, in general, you can expect that people's emotions will be running high. The good news is that means you really care about what you're doing. You're most likely clinicians of good conscience, and you're trying to figure out what the right thing to do is. The bad news is when people's emotions run high, they have a tendency to not communicate very effectively. Think about the last time you were really, really angry at your spouse or your children and how well that communication went until you cooled down your emotions. So we provide a safe space. We make it possible for people to enter into difficult conversations. We help clarify the plan of care. Sometimes in calling ethics, what happens is everybody gets in the room all at the same time and the plan is clear and they're like, okay, we don't really have a dilemma. We are happy to help. It's not often that it's that simple, but it is actually really nice when it does happen. So here's what we don't do. We do not function as the ethics police. I will say that ethics comes with baggage. Anybody who's been around in clinical practice for a long time knows that in the old days, people called ethics when somebody was behaving badly. And in fact, we still have physicians, it's usually physicians today, who, when there's an ethics consultation, make a comment along the lines of, well, somebody called ethics on me. And it's really not about them, it's about the patient. But sometimes it feels like it's about them. We're not, if you call me and tell me that Dr. Bob is behaving badly, I'm going to refer you to the Professional Standards Committee. If you tell me that Nurse Nancy is being difficult, I'm going to refer you to her nurse manager. We are not a policing force. We do not look for opportunities to make people behave better. We don't bill patients or the cost center, so our service is free. We are part of the bed rate, and that speaks to our all-volunteer army. We do not dictate the plan of care or write orders. In fact, we have multiple disciplines on call. None of us can take over the patient's plan of care. That remains with the attending physician, and we can't tell people what to do. We will not serve as a legal advisor or a risk management consultant. I do have the legal department and the risk manager phone numbers on speed dial for me because those questions are invariably related to ethics challenges, but I am not a lawyer. I will not give you legal advice, nor will anybody else on our consult service. Even if they are in fact trained as a lawyer, their role is to be an ethics consultant. If we have a legal question, we actually have a legal department whose job it is to represent the organization. And that's also what risk management does. So ethics consultation won't do that. We might recommend you give them a call, but we, in fact, are not going to do that. And I mentioned this before, we don't fix it. We wish we could fix it and make it simple and take away all of the problems that have arisen, but that's not something we're able to do. So here are some key points about the consultation service here, certainly on the main campus. Our service is available 24/7, 365 days a year. Now, I have to be clear about this because I do a general presentation to all new nurses who come into the organization. The nurse ethicist is not available 24/7. I am representing the Ethics Consultation Service, okay? So I've had people say, oh, it's so nice to know that a nurse, no, it's not me personally. This is the consultation service. The most effective way to get in touch with somebody on call is to go through the on-call operator, 962-5500, and ask to have the person on call for ethics paged. The reason for that is, I don't know about any of you, but I have in the past tried to page somebody and I have misdialed and wondered why the heck they were never calling me back. So if you go through the operator and we don't call in, they will track us down. They have our cell phone numbers, they have our home phone numbers, they have alternate office numbers. I'm pretty sure they have homing pigeons to track us down if need be. We also have a team of people on call. So if the person carrying the pager doesn't respond, they will start going down the list of people. So that is really the most effective way to get in touch with us. People, any person directly involved in a patient's plan of care may ask for help from ethics. And we do mean any person. Now, we do not accept anonymous requests. In other words, you can't call and go, psst, I have a problem. It's 5 South. We can't help you. But if you are in a very difficult situation and request a confidential request, you need to at least tell us who you are. We will do our very best to encourage you to talk openly with your team because that is always the best way to resolve things. But if you need confidentiality, we will protect that. Whoever you are, if you're directly involved in the patient's plan of care, we will accept the request for an ethics consultation. Our recommendations are not binding, they're advisory. We write notes in the patient's chart, we document a list of recommendations, and you are free to just read on and not do that. We hope that you don't. We spend actually some thoughtful time and energy trying to come up with reasonable recommendations, but we are advisory in the end. So the person requesting an ethics consultation shall not be subject to intimidation or reprisal. This language comes right out of the policy, and I'm going to revisit it before I'm done chatting with you. So stay tuned for that piece. So when should you call? When do you think? When's a good time? Well, if you disagree with one another, or you disagree with the patient's representative, we always say, or the patient, we always say that the time you question a patient's capacity is when they disagree with you, right? So now I will say, just because you disagree doesn't mean you should call ethics first. Think of when you were children and with your siblings. If you had a disagreement, you didn't automatically ask your parents to intervene right away. So there are things that you need to do first. But honestly, if you are disagreeing with one another or the surrogate or the patient themselves, that's a good time to call. If the case is unusual, unprecedented, or ethically complex, such as involving extremely limited resources, this would be a time to call. Anybody who's watched the news, so I feel badly for the folks in Oakland, California, who took care of the 13-year-old patient who was declared brain dead. Like that is a case where you absolutely should get somebody involved from ethics. It's clear that the stakes are pretty high. Or if you have an incapacitated patient, in other words, I cannot speak for myself, somebody's acting on my behalf, and I maybe disagree among themselves. Let's say they're default surrogates in the state of Indiana, and the sisters and the brothers and the parents are all fighting, and they can't figure out what's the right thing to do. So those are times when you might think to call. I have to credit Patty Bledsoe, who's in the audience, with sharing this picture with me. This is, sometimes the best way to describe it is there's just this big elephant in the room that nobody's talking about, and maybe that's a time that ethics can help you. I will tell you that I used to have a caption under this, like, what movie should I watch tonight? Like, maybe you should be addressing this big red and gold elephant in your room. So we're going to do a case, because everybody loves cases. It is kind of funny because in our ethics consultation service, people say, oh, it's fast. It'll only take a few minutes. And half an hour later, we're still trying to figure out the right thing to do. So here's our case. This is Mr. M. He's a 56-year-old. He's undergoing treatment for head and neck cancer. His initial treatment included surgery and radiation, which went well. He was recently admitted for complaints of increased neck pain and decreased oral intake. Tests reveal an epidural abscess in the cervical area. His wife is intense. That's how she's described by the team. When she is present, Mr. M speaks very little and seems to defer to her. When she's not around, Mr. M tells the nurses he's tired and he just wants to go home and stop treatment. The medical team feels that this patient has a good chance to recover. There's so much in this one tiny little paragraph. So how many of you know that patients will tell nurses things that they won't tell anybody else? Raise your hands. Yes, this happens all the time. And so nurses are put in a very awkward position. So should you call ethics? How many of you think yes or no? How many of you think yes? Clap, because nobody who's watching this can hear you. Just clap. How many of you think should we call ethics? Yeah, thank you for your confidence in us, but not yet. Not yet. So, before you call ethics, there are some things that you should do. This sounds crazy. Talk to the patient and family. Oddly enough, having that conversation might be the most beneficial thing that you do. For example, if nurses say to the patient, Mr. M, every time I do this, you tell me that you just want to go home and stop treatment. Have you had that conversation with your wife? Is there something that I can do to help you think about it? Is it, do you understand that if you go home and stop treatment, this is the consequence? How about we get Dr. Smith in here? Let's all talk about how we're going to make this work. By the way, an emotionally charged, difficult conversation to have, but an important one nonetheless. You really need to make an attempt to try and have a conversation with your teammates. Oddly enough, it's very common that many people involved in the care of a patient have different pieces and parts of the story, and they think they've shared the story completely, but in fact they haven't. And the best thing you can do is to say, hey, when I was with Mr. M the last 3 times, he keeps telling me he wants to go home. How about, Dr. Smith, I know you think that this patient's going to do well and possibly recover, but can we talk about this? What does it mean? Clarify your understanding of the situation. Maybe Mr. Smith or Mr. M thinks he can go home and stopping treatment just for a little while. He's just tired right now. He's going to come back in a few months. Maybe he doesn't understand things completely. Before you call ethics, and I will tell you, these are notes that I always look for in the chart when I'm on call. If you've called us, I want to know, have you tried somebody from social work? Our social work colleagues are experts at navigating all sorts of challenging situations. Have you tapped into our chaplain service? Does the family have their own chaplain service? What can you do to help support them in that way? And how about our palliative care service? Now, I will tell you, as an ethics person on call, when it's the palliative care service calling for the ethics consult, I know that we're in deep woods already because they are experts in having very difficult conversations, particularly about goals of care. So before you've called ethics, well, I'm really happy that some of you wanted to call right away. We're going to ask, have you done these things first? Have you done these things first? So, of course, our story continues. Things don't go well. Nobody calls ethics when they're having a good time. Let's be clear about that. So over the next 2 weeks, Mr. M's condition has deteriorated. He developed strep pneumonia and MSSA, anemia, and thrombocytopenia. He was urgently intubated, and despite lightening up on sedation, he's been unresponsive for 48 hours. It's been a tumultuous week with stressful family conferences, including Mrs. M and Mr. M's sister, who don't seem to get along. The medical team is concerned about renal failure and the possible need to start dialysis, and they're much more concerned that Mr. M will not recover from his multiple problems. Now, I will tell you, you may think you know this case, but you don't. This is a case that is a conglomeration of typical cases that come to the Ethics Consultation Service. So I just want to let you know, in the interest of HIPAA, this isn't somebody you know, even if you think you know him. All right. So, and I'm sure some of you do. So Mr. M's sister states that the patient told her he would not want continued therapy, that he would want support to be withdrawn. His wife denies this. She's hopeful that he'll recover. She feels everything needs to be done to give him the best chance to recover. There are no written advance directives or formal surrogate decision maker appointments, so we have to go to Indiana default law. The patient's code status has changed from DNR to full code and back to DNR. And that is well-intended clinicians having conversation with the person they think is the designated surrogate, and things just happen. 2 family care conferences have occurred in the last week, during which family members freely expressed their anger and emotional distress, most notably directed at the team. Again, it's not who you think it is. So now what? Call ethics? Clap. Yes, now it's time. Really, it is time. Really, call us. We can help you because you've involved palliative care. You've involved the social workers. You've involved the chaplains. And you are essentially at an impasse trying to figure out what's the right thing to do. Now, when you call ethics, we do not expect you to call and say, this patient's autonomy is being undermined because the surrogate doesn't have the patient's best interests at heart and it's not a beneficent situation. Nobody talks like that. Nobody talks like that. And if you do, we will have serious concerns about you. So there are many different ways of framing ethical questions related to this case. The first one is, who is the appropriate surrogate for Mr. M? Now, there are legal pieces of this which we need to pay attention to. I've already said that there are no designated surrogates by the patient. So who is, if they're default, then they're equal. So many people have a bias, not uncommon if you happen to be married, that the spouse should carry more weight than the sister. And so some of this is, who really should we be listened to? Because clearly they don't agree. What standard should we use in making the decision about this patient's treatment? Should we go with what the sister says, which would be patient's prior expressed wishes? Should we go with the wife who knows him best? Is she focused on what she thinks he would want? It's not clear. Is it ethically appropriate to limit life-prolonging procedures for Mr. M? Can we say no? Is that ethically defensible? All of those are important ethics questions that we might want to ask in relation to this case. So what happens when you call? First of all, we're going to promptly answer your page. Our goal is to get back to you within 30 minutes at the most. We aim for something much shorter than that. Again, the operators will find us if you don't get satisfaction. We're going to get some information from you about the patient. Now, anybody, our fellows in the audience will tell you when they first take call, the first time they get a call from somebody about ethics consultation, as soon as you say, hi, I'm so-and-so from the Ethics Consultation Service, you should get your pen ready and wait, because the person who's called you is most likely in a very stressful situation, and they're going to start telling their story before you can slow them down. But if you haven't told us in the story these key pieces of information, we're going to ask you for them. We need the patient's medical record number. We need Can you tell us the ethical problem? Now, again, we don't want you to speak in beneficent, non-maleficent terms. We want you to tell us what you think is the issue in your own words. Leave it up to us. We will try and frame it in terms of ethically appropriate or formal language. Why did you call us? What were you hoping we could do for you? Whether or not we're able to achieve that goal, it helps us think about how we can help you. We will always ensure that the staff attending physician knows, and I want to spend a little bit of time on this. Our staff attending physicians are ultimately responsible for a patient's plan of care. For the most part, as far as I know, each of them are physicians and clinicians of good conscience. They want to do what's right for patients. And when the staff attending physician hears from the ethics person on call that somebody's called ethics, it feels crummy for a variety of reasons. Because whether it's, somebody's questioning my judgment, or somebody didn't think that I was approachable enough to be able to talk to about this and they had a genuine concern, which is why we always encourage you to reach out to the staff attending physician first. We are happy to tell them, and sometimes it's a simultaneous call. Sometimes it's funny, a lot of nurses feel like they are the most vulnerable. For me, the most vulnerable person on a team is probably the intern or the resident who has some concerns, and they really don't feel comfortable with their staff attending physician. We don't want to undermine that relationship. We will do everything we can to nurture and support you in speaking directly with the staff attending physician, but they're ultimately responsible. They can't write the order, and in fact, since anyone can request help from ethics, the staff attending physician can't say no. They can't decline the request. That's a different problem. But in general, please, please, please talk with each other. Make every effort you can to speak among yourselves. Because that honestly, in many cases, will resolve what you thought was a dilemma in the first place. So we are going to talk with other people involved in the patient's care. If a social worker calls, we're still going to talk to the bedside nurse, the staff attending physician, talk to family members. We're going to identify ethically appropriate choices. Sometimes what that means is, well, we always review the chart without question. We will sometimes actually go to the literature. We will look up policies that are relevant to our organization. We may look up policies from professional bodies that may speak to the topic. And again, we function as advisors. Our goal is to help you figure out how to make this better for the patient. So let's go back to Mr. M. What would we say? So things to pull out that are important. The language that's important from an ethics standpoint is there are significant benefits and burdens to be considered. This patient seems to be experiencing significant burden, and it's unclear if there is a benefit for him. In terms of his best interest, we ask surrogates to act on behalf of the patient, and that can be a very difficult thing to do because sometimes their thinking what's right for the patient is colored by what they themselves want. And it's a very difficult situation to get people to think about not what you would want, but what do you think this patient would want, and or what's in this patient's best interest, meaning if the patient wants it, but wanting it isn't going to get them to the place where they want to be ultimately, how can we identify what's going to help them achieve and what goals, frankly, are achievable? So we would make some recommendations in the care. It would be ethically appropriate based on the medical situation and, the sister's words. We presume that people are truthful, that they don't lie to us, to withdraw care. However, and here's the hard part, in view of the family conflict, the Ethics Consultation Service would advise that continuing care, maximizing pain and symptom control is acceptable, at least temporarily. One of the most effective recommendations we can make is set a time-limited course of treatment. So even if you're holding the course right now and people have genuine concerns, set a time limit for how long you can tolerate the status quo, particularly if a patient's in an ICU. Except in the neonatal population, where the longer you're in the ICU, the better your likelihood of recovery is. In the adult population, if you're still in the ICU and you've made no forward progress, that is, in some senses, a poor prognostic indicator. So the main goals are to reduce his suffering. No matter what, this patient could be experiencing some suffering, prevent unnecessary suffering, maintain connections with the family members. This is really, really hard because clearly the family's distressed. They have perhaps lost trust in the team, maybe trust in each other. It's a difficult situation. Now, even if we have involved our chaplain and palliative care service, in the Ethics Consult Service, we might remind people, maybe the family has a personal spiritual support person that hasn't been tapped into. Bring them in and see, can you help them? So that's how we would look at it. So that's a snapshot of a case. I want to share with you some data that we have about our own consultation service that we obtained as a result of a values grant. We did a sort of a quality analysis of how we were doing with our ethics consultation service. I want to tell you a little bit about that, and then I'd like to open it up for questions because I'm sure no matter how much I say, there's always more to be said. So people ask, so who calls the consult service? If you look at this grid, it shows that nurses, physicians, social workers, everybody, if you sort of lump people together between nurses and physicians, about a third of our requests come from nurses, a third come from physicians, and then the other third is social workers and a bunch of other people who are part of the team. It is rare, but we do sometimes get a request directly from patients or family members themselves. We do get those, and sometimes those calls come because a member of the team has recommended that the family ask for it. So we asked people when we did our project, so why'd you call? What motivated you for calling? My favorite in this is someone asked me to make the call. I love the fact that people were honest when they answered this survey. I'm only doing what I was told. But in general, people had some ethical concerns about the patient's plan of care. This little subset of I had concerns about ethical behaviors of people on the team, that's not something we would deal with. We would have referred them to someone else. And then there's sort of a hodgepodge of other reasons why people called. So we asked them, what did you expect of us? What did you hope that we could do for you? So you can see from this, basically facilitating communication is the biggest thing that people expect from us. They want a neutral perspective. They want to know, hey, are we doing the right thing? Now here's why I appreciate our consult service and our model of anybody can ask for help. Sometimes, honestly, people are calling for reassurance. They think they know the right thing to do. They're pretty sure, but it would really help to hear from an outsider that, yes, what we're doing is ethical and it's defensible and it's the right thing for the patient. So this just shows you more of what people expected of us. So I talked earlier about negative consequences. What does it mean to experience negative consequences? We actually had one of our fellows do a project where she interviewed nurses who had experienced what was it like to make a request for ethics consultation. And in our study, which was more recent than that, we asked, if you were the one who called, did you experience any negative consequences? These are examples of negative consequences that were experienced. In the study that we did, and our data collection closed 2012, we had about 10% of people identify that they had experienced negative consequences as a result of calling. So some of it was being yelled at. Now there's being yelled at in private and there's being yelled at in public, which is public humiliation. Sometimes assignments were changed. Sometimes people received the cold shoulder treatment. And in general, fractured relationships were what happened. I think what was striking for me, it still continues to be, is these sort of negative consequences come not from just physicians, they come from nurses as well. Nurses and physicians, when they disagree with somebody asking for help from an outsider, they're not very shy about showing their displeasure. So in our policy, we state that anybody who requests help should expect to do that free of retribution. The problem is, if you don't tell the Ethics Consultation Service that you experienced this, we can't help you. We also, and realistically, we can't inoculate you against retribution that you might experience. But if it's brought to our attention, we will in fact address it. It is uncommon, thankfully, but we are happy to address it. Many times it is a misunderstanding. I know recently we had a situation where one person on the team requested an ethics consult and somebody else on the team canceled it. So really the only person who can cancel a consult is the person who asked for it in the first place, because we're going to navigate, is your problem resolved, or are you getting pressure, or, what's happening? And it was an awkward enough situation that, we sort of paid attention. The coolest part about it was, as I tapped into how do we deal with the negative consequences that this person experienced, everybody I called said, well, anybody can call an ethics consult. Anybody. That was so awesome. And the individual who called got support from her direct line report, from other people on the team, from the staff attending physician. It was actually a wonderful, the good news is she experienced negative consequences and she got support from other people on the team. Also, the really awesome news is the patient, because this person raised a concern, got better care. The team was able to uncover something about her decision making, which was much more subtle and hard to identify. So the good news is the patient got better care because somebody honestly asked for help from the outside. So how much time does this take? Well, when we did this study, we had 94 total cases, and much like everybody else, only 90 of our ethics consultants completed their paperwork on this particular part of our case files. We keep case files in the Fairbanks Center, which are different from chart notes. So we had a total documented hours, 262. The range is anywhere from about less than a quarter hour to 13 hours. And those 13 hours are not consecutive, thankfully, but they do happen over a period of time. So there are times when our ethics consultants who are on call spend a significant amount of time trying to help people going forward, whether it's doing interviews, doing chart reviews, attending family meetings. There are a variety of things that they do. So we measured some outcomes, like were people satisfied? People, almost 80% of the time, people felt like they received support. We validated the team approach. That actually would be an example of assurance, which is a good thing. We helped to solve a problem, yay. And then we provided education, both a better understanding of ethics issues, which is nice, so helped people sort through what was bothering them and how to frame it in ethics language. We clarified some uncertainty, and in general, we tried to explain things really well. So in the ethics literature, people talk about ethicality. So it's a strange word on a good day. So if the goal is the service is to provide individuals and teams with assistance, the goal of the consultation is really to promote and support sound ethical reasoning. So this ethicality is ethical reasoning. So in order to do that, we have to demonstrate respect for people's values, because these are value-laden situations. We have to help people, if we can, clarify their own values and help them understand maybe why they had a conflict, why they were distressed about the situation. We help clarify the patient and family's values, and that actually is a really good thing. I wish we could do that or demonstrate that we did that more frequently, because understanding the patient and family's values are a good way to understand the ethical nature of the question, consistent with personal values and, of course, with IU Health's values. So these are some types of ethical conflict that we identify in our case files in the Fairbanks Center. Intra-family conflict or conflict with the team. Undertreated pain is something that comes up, sadly, not infrequently. Provider concerns about patient suffering. Team objects to the patient or family choice. And that one is somewhat challenging, because sometimes that is an ethically appropriate objection, and sometimes it's you need to explore your values and identify that what they're choosing is ethically defensible. Scarce resources invariably challenge people to think about, are they doing the right thing? It is not uncommon when you say to a patient's surrogate, we have to have some difficult conversations, and then they evaporate for 3 or 4 days, and you don't see them in the hospital. This is what we call avoidant behavior. And it's not uncommon, and sometimes that is actually why we get called for help with that. And maybe there's lack of consensus on the plan of care. So these are some common ethics issues. I could spend a whole other hour talking about moral distress. I won't, but basically it's people who are really struggling because they feel like they're not doing the right thing for the patient. Non-beneficial or futile treatment, quality of life issues, patient best interest, code status. These are some of the common reasons why we call. If I were going to say like the top 10 reasons, these are some of the top reasons why. By the way, when I talk about this, I always say clinicians do hard work every day and navigate ethically challenging situations without the help of the Ethics Consultation Service on a regular basis. You do hard work, and we're grateful for that, because if we had to be called for every one of these conversations, we would not get any of our other work done. So I want to say thank you for all the hard work that you do in terms of navigating these difficult situations. We're very happy to help when it doesn't go well, but in general, clinicians do navigate these quite well on their own. So what do we do when we call? Like, what do people say we did for them? Well, we gave them advice. We were present at a family meeting. Sometimes it's just, yes, we're here. We're going to support you. We facilitate communication. Sometimes the team needs a little bit of moral support. We do provide assurance. We act as that neutral person. And again, we mediate, do some sort of conflict resolution. So we asked people in this project, did the patient's plan of care change? Only 30% of the time do people say, yes, the plan of care changed. But even saying that, in general, well, not in general, 3/4 of the time, people's confidence in the plan of care was increased as a result of involving ethics in the case. So it seems like we're not doing harm. That's good news for us. And it gives people confidence that they are, in fact, doing the right thing. So this is some feedback, some examples of narrative stuff that we got. So the team felt he was going to die, and the family wanted everything done. He was suffering. There were nurses who felt like we were prolonging the dying. And I think part of it was the way the family were getting information. The ethics consult kind of changed the conversation. Reframing is probably our most valuable tool in ethics. It's not always just giving them the information, it's how you frame it. I think in retrospect, I wish we had called the ethics consult sooner. So both good news and bad news for us. One of the things that we struggle with is, what is the right number of ethics consults to have in your institution? Is it based on the number of beds? Is it based on the number of critical care? Nobody knows. Like, people say, oh, your rate of ethics consultation dropped. Nobody's asking for help and they really need it. When in fact, no, it's because they're actually figuring it out by themselves, and they're navigating these difficult situations without us. Oh, you had a big spike in ethics consultation requests. Is that good or bad news? Hard to tell. If we offered a benefit to the team, that's not a bad thing. So what's the impact on providers? In ethics consultation, we talk a lot about what's the impact on the patient, are we doing the right thing? And I've come to appreciate that ethics consultation for a lot of us is really about supporting the team in the work that they do. So if I hadn't been a part of the consultation, I probably would have still believed that we should have done what the family wished to do. So being part of the consultation helped me see the whole picture. There are people who wonder, did I do the right thing? What if, what not? And so I think one of our biggest challenges is making sure that everybody who's involved in the plan of care knows how the ethics intervention was helpful. And then, it helped me realize that there's no right or wrong, but shades of gray. And that's why we get an ethics consult. I realize they can't tell us what we should do, but ethics consultation helps us discuss all the variables that really helped. So that's kind of the definition of ethics consultation. So, good for us. And I will say, people say all the time, it's not black and white, it's gray. For me, ethics is technicolor. I've said that before, because people who are involved in an ethically challenging situation are most generally emotionally invested in the right thing to do. And very few people would describe that situation as being gray. So if you're not at the academic health center, and there are people who are broadcasting in, how do you get help from ethics? So I will say that all of our facilities are either Joint Commission or other regulatory body certified. And within that, everybody's required to have a mechanism in place to deal with ethics issues. So each organization has its own protocol. There are variations. I would say contact your chaplain's office, might be able to help you identify, your hospital operator, medical staff. All of our ethics infrastructure is housed within the medical staff model. All of those are individuals who can help. You can call us at the Fairbanks Center, and we will try and help you navigate who to speak with at your home institution. We do not go on the road around the state. Although our programs, we would love for people to come and enjoy them here. That is what I have to say, and I was encouraged to leave real time for questions. So I've left 15 minutes, and I'm going to ask my colleagues with portable microphones, because if you raise your hand like this, I'm not going to see you. So if anybody has any questions, be really obvious. Eamon will come at you with a microphone. And if nobody has questions, gift of time, and you get to leave early. Amy's, oh, there she goes. I'm like, okay, Amy's not going to move. Like,
Thank you for the presentation. It was very comprehensive and insightful. And I guess my question, I'm Elliot Bedford, I'm from St. Vincent. So we just wanted to come over and see how things are done over here at IU. It's fantastic. And I'm just wondering, the survey that you're able to do to be able to gather information, how often do you guys do that? Is it how much time and energy?
I swear this is not a plant. For my colleagues in the Fairbanks Center, we have been struggling with. We were able to do this because we had a values grant and we had funding to hire a research assistant to do the work. So on an ongoing basis, as a volunteer army and a foundation-supported, endowment-funded center, we don't have resources right now to continue to do the work. What Lexi didn't mention about me is I co-chair the consultation service here on the main campus. I also chair the Clinical Ethics Consultation Affairs Committee at the American Society for Bioethics and Humanities. And I think any service that provides high quality should have the resources to monitor their quality, but we're not there yet. So I'm happy to share with you what we used, but I will tell you, you need resources to do it.
Yeah, we're
That's
in the same
bottom
boat
line.
then. Yeah.
Other questions? say let them go. Amy, what do you say? Thanks for coming. Gift of time.